Welcome to Speaking in Spoons with your host, Christina Brookman.
Hi, I am Christina Brookman, your host with Speaking in Spoons, a chronically ill podcast. And today we are talking about standardized patient programs. And with us, we have Stacy Reardon Hall, coordinator of standardized patient programs at VCU. Thank you for being with us, Stacy.
Hi.
Um, I,
Um,
so why don't you tell us a little bit about yourself and the program at VCU?
I come from a theater background, and about 12 years ago, I got an email from my husband saying, "Hey, my old college professor is starting this program with where actors go in and play the roles, and doctors practice being doctors." And I was like, "That sounds neat," and I don't have a job. So what ended up happening is I got hired and I was part of the pilot program with VCU standardized patients, and I've been there for over a decade. So it's been pretty wild and wonderful, and it's the strangest job. It is hard to talk about at parties because people don't believe it's a real job. But now I run the SP portion of things at the Center for Human Simulation and Patient Safety at VCU.
That's incredible. And I think it's such an important job. And these type of the reason I wanted to have you here today is these type of programs are becoming, they're popping up more and more across the country. I think they should be everywhere because, you know, it's really a great way to train doctors on the bedside manner, diagnosis process, all of that. I'd love to hear from you more, like since you've been there since the infancy, how has the program changed?
Oh, so much. We started out and we were picking up little things here and there. They would need to, we would find out, hey, this part of the program needs to train in this kind of item, and we would plug in, and eventually, within about 2 years, our program basically started becoming the simulation for all VCU medical, including a lot of the professional programs. Uh, People who are already doctors come to us, and
Oh,
they
great.
work on skills as well. So we started out as sort of just, hey, let's see how we can make people better communicators, and we grew into, okay, so we also know um, how an abdominal exam is supposed to feel, so we can tell someone, hey, you're not palpating or basically touching with intention deep
Right.
enough to feel what you need to feel, and things like that. And it's grown, and it's been wonderful. It's you I think a lot of people go into theater and you think to yourself, art for art's sake, and we need the arts, and we absolutely do. But this very much so scratches my personal itch of arts can be pragmatic too. Um,
Absolutely. Yeah,
and
I
this
love
program
that.
really does that. It takes a skill that not a whole lot of people have. Performance and communication, being able to do both of those things, it's a very niche skill. And the people who do it, they're doing such wonderful things.
And it sounds like you really found your purpose. Um, doing this. And
Very
I'd
much.
love to hear. I was excited when you said that this is also kind of a continuing education program for doctors that are already doctors. So it's not just med students, it's also people that already have their MD
Yes,
are
absolutely.
coming in.
We work with fellowships, we work with interns and residents, and of course, we also work with all 4 years of med school.
That's incredible. Um, I was curious, have you ever like, so I know, how do you I know you have a connection in the theater community. How do you hire your actors and search for actors, and what skills do they particularly need for this type of program?
So we don't just hire actors from the theater. We hire anyone who has the right skill set. But
Okay.
most of our hiring goes through, well, all of our hiring goes through VCU's process. So people go to the VCU employment webpage and they fill out an application just like anybody else. I personally know that folks in theater tend to have a strong skill set. They have at least one of the items that you need to be a good standardized patient or SP. And so I always I post on theater pages, hey, this program's hiring. It's great for people who are in theater or the arts. And we usually get we get a lot of answers back to that. And it's great. The skill set that's needed is, one, you've got to be able to memorize stuff because you may be doing 4 or 5 different cases a week. So you have to have that ability to look at the information of the case and remember that you are taking Advil and not Tylenol or whatever's on there. You have to be able to remember what happened in the encounter. So you have to be able to act and also process what's happening around you so that you can tell a student, hey, when I told you about my sexual history, I noticed that you stopped making eye contact and backed up towards the corner of the room. Can you tell me more about that? And being able to remember those moments so that you can discuss them so that the student can make an educated decision on how they want to improve upon that. And sometimes whether or not they want to improve upon that, because
Okay.
sometimes sometimes some of the feedback that you get, it's about knowing that feedback is there and deciding whether or not you want to do it personally in the way you practice medicine.
And how are they given feedback by the standardized patients? Are there other people that are giving them feedback? Like, walk us through a day in a stimulated or simulated experience.
It's kind of both. No, it's the we so a typical day, an SP can do anywhere between 4 and 6 encounters generally. And what they do is they usually have about 20 minutes with their student, and the student interviews them and does a physical exam if necessary. And then after they finish, they have a, a relatively short time. They have 5 minutes to give feedback. The feedback is based off of the advocacy and inquiry method, which is I use it all the time. I use it with my 7-year-old at home. But the idea of the advocacy and inquiry method is to not just say, hey, this is my feedback, but to also get information back from the person so that can be part of the feedback. So talking about the sexual history question, because that's something that comes up quite a bit.
Right.
And different people of different backgrounds have different comfort levels with talking about sexual history. So if I were to look at a student and say, hey, I noticed that when we were talking about sexual history, you backed away from me and stopped making eye contact. So that's the objective part of it. You want to give something that is objective, something that if you go back to the tapes, you can you can look at and you can say, yes, this is a thing that happened,
Right.
which is why I would say, I noticed that you broke eye contact and backed up, instead of saying something like, I noticed you were uncomfortable. Because uncomfortable, that's subjective. We don't know if that person felt uncomfortable or if they felt any number of things. Um, so you would tell them what they did, and then you would say, can you tell me more about that? And that gives them a moment to really process what they were doing at that stage. And they'll usually say something like, I didn't even know I did that, but I was so nervous.
Right.
And
Yeah.
and then the SP can process that as well and say, okay, I understand your perspective. As the patient in that moment, I felt judged, or I felt uncomfortable, or I felt whatever their feeling was in that moment. So in the future, I recommend that you maintain positive and open body language, even when talking about uncomfortable subjects.
I think that's incredible because I know as patients, we can often feel a lot of feelings, overwhelmed, feel like, particularly patients with chronic disorders and disabilities or rare disorders, feel like we're not being heard and feel like uh doctors aren't really taking the time to listen, or they're judging us, and that may not even be the case. They may have, 100 appointments that day and they're rushed and they don't realize what their body language is. So I think it's really amazing that the doctors are given this feedback in such a an objective and then conversational way too, so they can be made aware of that before it becomes a confrontational issue with patients, and then it can really better help their patient care and help the experiences for patients. Are the doctors given? I loved how you mentioned the example of this is how this came across. Maybe keep eye contact, keep an open body language. Are there any tools or specific classes that they are given outside of this to help with the feedback processing and then um, further implementation? Just
So,
curious.
they all are working with their faculty members, and we also encourage them to go and talk to their faculty members about, hey, this is what I experienced as a patient. Go and talk to your faculty members about what they use, what tools they have in their toolbox to be able to do these things well.
Okay.
We're expanding all the time. I would love for there to one day be a class on how to take feedback, how to absorb information. Um,
Yes.
those, I think those are just communication in general, which
Like
of
an
course
improv class.
yes, actually. So Erin Anderson
Yes.
has started an improv class um, that is mostly medical students.
Oh, that's
Um,
incredible. It
yeah,
really is.
it's so cool because they have this opportunity to take a more yes and approach to
Yeah.
being a medical professional, and just in general. I mean, even if you never do improv that's medically based, even if they were to never touch that, just the idea of playing improv games, things that make your brain go boop boop, and it's a wonderful way to make your brain grow, get those neurons firing
Hmm.
so that when someone tells you a random disparate group of symptoms, your brain goes to a place that maybe it wouldn't have gone if you hadn't trained your brain to do that.
Absolutely. Think out of the box
Yes.
and be able to tolerate stress in a different kind of way. Like I think I was meant to train in acting because it's like the universe knew my body was going to face these challenges and disability later. And if I hadn't, and I was engaged to a stage manager once, and I was like, how do you do this? And he said, just remember, everything's always your fault, even if it isn't, and let it roll off your back like a duck,
Uh,
like water rolls off a duck. That was the best advice anybody's given me about that, because I think about that now in regards to stress. Just keep focusing, keep going. And I think those games, like you're talking about, really help you not internalize it and not um
not brew on it.
exactly, don't live there. But also, I was curious, do you have programs um or now, or like for the future, where you have standardized patients with lived experience of that come in to talk to the doctors of to what it's like, um the experiences they like, sharing stories of experiences they have had or anything like that?
So we do have we have some of that, but we don't have anything that's a dedicated program there. And
Okay.
honestly, that's something I would love to see in the future, is for people to be able to come in and talk about their experiences
Yeah.
in an interactive way. And I do know that they do some of this in their classes, but it's not
Right.
specifically with our program.
Yeah.
Um, I think it's so important to know what people feel.
Yes.
Several years ago, we started we started working with the medical program on how to address people who are trans or gender non-binary, and working with folks to make sure that the way that we're communicating is a way that feels accepting and empowering. And
Yes.
that's huge. It's a huge thing, because one of the, and this is important not just for folks in the LGBTQIA plus community, but also in the Spoons community, is the idea of going to the doctor. The moment itself, yes, it's very important to get your immediate concerns taken care of, because if you walk in and you are throwing up, yeah, you want something for that. But it's not just that moment. It's not about healing someone in just one moment and one day. It's about creating an environment to where they want to come back. Um,
Absolutely. And if
and
you're not listening to them, really listening, you're not making them feel welcome enough to talk and comfortable enough to talk enough, you're going to miss things. My mom's primary care has missed every single major diagnosis in her life. She's
yeah,
now had to start going to outside providers and get information. I was misdiagnosed with something psychological, pseudo seizures, for 10 years, to come and find out it was hemiplegic migraines, where it's like a stroke on the right side of your body, and also with convulsions when I'm overheated. And that happens a lot. People are told it's conversion disorder, it's in your head. When in the statistics, it's statistically higher for women, because the disorders that this is happening for are women's disorders that are under researched and underfunded. So I love what you're talking about, particularly for the community, that community, because, imagine being in that community and also having chronic illness or disability, which absolutely happens, and then you can't talk about it. Or there are teenagers that are wanting to talk about important issues and they're at a higher suicidal rate, you
yeah.
know. So I am so in awe of the work that you guys are doing. I think it's incredible. Do you have are you um, able to share any plans for the growth of the program?
So we're the growth of our program is deeply based in folks realizing, hey, we need to get better at this, and let's find a way to do that. And that's been a huge part of our growth, is someone saying, hey, we want to decrease medical errors. how can we do a simulation that helps identify the issues? And so we
Yeah.
sit down with the client and work through all of those things. We have events that are we do several bad news cases, like we do a pregnancy loss event, which is it's a tough one to watch. I'm a
Yeah.
person who's had a pregnancy loss. We do an event that we do a telling a family member about another family member's brain death situation. We have several cases that are um, that came up because the client said we need to get better at this, and so we help them create a case that allows them to practice it in a way that they can get better at it, and
In a
that's
safe environment
in
too.
a safe
That it's
environment.
okay to be wrong and can just continue that practice.
Well, and
You
I
know,
think I think you will really like this. Our program, our one of the things that is central to the entire program is what we call the basic assumption, which is every day the basic assumption is every person who is involved in any simulation is doing the best they can on that day.
mhm.
Um, and it doesn't matter if someone seems grumpy about doing a simulation, or if someone seems like they don't want to be there. No, it's not that. It's that today, this is their best. And tomorrow their best might be different. It might be better, it might be worse, but today is the best that they can do. And so they're going to take that information and they're going to use that to make them either a better provider or a better patient or whoever they are. They're going to be a little bit better because they had that experience today. Even,
Absolutely. Yeah.
yeah. And one of the first questions we ask in feedback is, if you could do this again, what would you change? And sometimes it's things that they would change during the encounter. Sometimes, we've heard people say, I was hoping I was going to have a male patient because I didn't want to have to deal with draping. Um, Sometimes it's things I wish I had not stayed up so late playing board games with my friends last night because I'm exhausted today.
Yeah.
So all of those moments are lessons, and they're great lessons, even if in the moment you wouldn't consider them victories, they are.
Yeah. Lessons are important.
Yes.
That's how we get better, you know. So that's I love your spirit and your outlook on that. They're very lucky to have you. Um uh um and I'm very, as a patient, I'm very grateful that programs like this exist. And that we have advocates that are working to constantly, daily look at programs and go, how can we improve this and make it grow and be even better? Do you have simulations for children and their families?
So we have done simulations where we have adolescent pediatric
Hmm.
simulations where people who are in fact adults play the roles, because our the way our program works is we are 18 plus, because those are the university guidelines.
Right.
Um, but we have done several events where you are talking to a set of parents about their kid, or about their pregnancy or about their baby. And we have these just magnificent mannequins that are so cool. One of them is called Hal, and he's about the size of my 7-year-old. And if you put your hand on his little head and stroke it, his little eyes will make eye contact with you.
Oh, that's cool.
It's so cool. Now some people are like, oh, nope, 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 that's not for me. But for me, I'm like, I love these mannequins.
Are they able to adjust that? Like, because I know there are,
Mhm.
children with neurodivergencies, autism on the scale that may not be able to make eye contact. How do they do that?
Yeah, there's different programming that you can use where the patient can make eye contact, but they don't have to. They have
Okay.
pupils that dilate and constrict.
Oh,
So
nice.
yeah, so they can have seizures. You
Right.
They have lights, so inside, so if the mouth can turn blue to indicate they're not getting enough oxygen.
Oh, that is
Um,
so cool.
you can check their pulses. It's these things are so very cool. And
And then
I
you're not necessarily traumatizing a child through an experience, but
exactly.
you're able to provide symptoms that you might be dealing with for diagnosis.
Oh, and they can sweat and they can
Oh,
cry,
wow.
like cry actual tears. It's amazing. The technology is amazing. But the human element is my primary thing. That's
Yeah.
where I am is helping people to become better communicators. And that's really the main thing is you want someone who can listen to you and make you feel like your experience is a worthy experience. Um,
You matter.
yeah, it's about making sure that every patient feels like their experience matters, it's unique to them, and that what they're feeling is okay.
And I know with a lot of our listeners out there, there are a lot of quote unquote zebras out there, and zebras do exist. And I know doctors are often told if you hear hoofbeats,
It's
think
horses, the
horse, not
zebras
zebra. But the funny thing is, like, I have Ehlers-Danlos, I have hypermobile Ehlers-Danlos. It's not rare. It's just the other forms of Ehlers-Danlos are rare, but my particular form is not. I have other rare disorders, but
Mhm.
the Ehlers-Danlos isn't. It's just there are very few um, physicians that truly
Get it.
get it and are comfortable making diagnoses because they're because of that too. Um, so
Yeah. My experience in diagnosis is I had really absolutely horrendous periods for 30 years.
yeah,
I got a hysterectomy back in April and it changed my life for the better. And but I had been talking to doctors for decades about, hey, sometimes, it's like I've sometimes I bleed for weeks.
yeah.
And the overwhelming response up until about a year and a half ago has been, well, yeah, some people just have sucky periods. It's like, but eventually I got a diagnosis of adenomyosis and I
Hmm.
got a hysterectomy. Um, and all of that and when they found out, when they did the pathology report, even though I had a diagnosis of adenomyosis, the pathology did not indicate adenomyosis at all, which is fine because regardless of whatever I had or whatever reasons, the hysterectomy is what made my quality of life better.
Well, and
And
with a lot of those disorders, even the pathology, like I know with Sjogren's, I think it's 98, 99% of blood work gives you a false negative. And even the biopsy isn't a sure thing. So, like you said, it's taking care of what you needed to have taken care of. And a lot of people don't want to talk about those kind of, you know, those kind of things. So,
uh, and the doctor who did my hysterectomy, who is amazing and wonderful, um, is also someone who's a faculty member. So I'm so glad that this person is teaching the next generation.
other people, yeah,
But what she told me was, so your pathology report came back as negative for adenomyosis, but but that's not something that you need to worry about. If we took it out and you feel better, then we made the right decision.
yeah,
And I was like, oh, yay. It's just good to feel validated
yes.
in such a real way.
Validation is huge. And I know a lot of people worry about labels or giving other, like, doctors don't like to put labels, parents don't want labels. But as a patient, sometimes, and I hear this experience coming from you, is that sometimes those labels are validation because you're like, oh, it wasn't all in my head. This was real. And this did matter. And I guess my thing too is, even if it is in somebody's head, well, neurological, it is in your head, but let's say it's psychological, they still deserve to be treated like a human being. There shouldn't be a different level of treatment. Um, I'm so grateful for you for coming today and talking with us and sharing about the program. I think a lot of listeners are going to be excited to hear about this. Do you have any final thoughts or things you'd like to share with our followers?
Um, just that I love this work because it makes a difference. I've been doing it for over a decade now, and I've gotten a chance to see the results of it in my own medical care and in my children's medical care. When I gave birth to my son in 2016, two of the doctors who examined him were part of our first cohort of students that came in,
Oh,
and
that's
they were
incredible.
wonderful. And their communication techniques were wonderful. And part of that is because they got to practice it. And I think that that's probably the most important thing in communication, is to keep practicing and to keep asking questions. We get students every day who are like, okay, so last time my SP told me this. Did I improve on that? And so I think that you got to ask the questions and keep practicing, because all the studies show that the more you practice in simulation, the better you get.
Yeah, that's incredible. And that it's okay to be wrong. It's
Okay to be
okay to
wrong.
have a failure because we're human. Like, I think there's a pressure on doctors to know everything and be everything. And and also for patients, they're like, well, they have the medical degree, then they're God. But on both sides, everybody's human and everybody makes mistakes, and that's okay.
And
So it's
we actually
yeah,
do that. There's a thing that we call the discernment question. And it's a question that a patient asks in every encounter, just about, that is something that they couldn't possibly have the answer to yet. And it's to get the students used to being able to say, you know what, we don't know that yet, or I don't
oh,
know. I love
bless
it
you.
so much.
Yeah. I don't know, but I'll be with you on this journey, and I'll help you find out the answer. Maybe direct
Yes.
you to yes, that's
Yeah,
incredible.
I
That's
love
everything. Those
it.
are my favorite doctors. The ones that can, because even doctors that have been doing this for 60 years, there's still something they don't know. Medicine science is always changing.
Yeah, it's huge, and and you can't possibly know everything.
No, there's
I
no
love
way.
the fact that I asked my doctor, last time I went in for my yearly physical. I asked if a new medication they were prescribing would mix with any of my other medications. And instead of saying no or maybe, they just sat down and looked it up, because they
Yeah,
didn't know off the top of their head, and they're not
yeah,
supposed to.
right.
There,
No, I think that's great.
there are guidebooks for that.
Yeah.
It's
No,
okay
and
for you
you're a
to,
part of that.
yeah,
That's
it's
wonderful.
okay to read the instructions. It's okay to
Yes,
follow the map.
please read the instructions. Please ask questions. And please tell your patients you don't know. Like, it's okay to have hubris. It's good. It makes you a better doctor.
Yeah.
So, um, well, thank you, Stacy. And
Thank you for having me.
oh, absolutely. Really appreciate you doing this. And for those listening and watching, stay tuned, because Nate and I will be back after the break for our after party to discuss the interview and save your spoons. Hi, welcome back. This is Speaking in Spoons After Party with your host, Christina Brookman and Dr. Nate Strauss. We just interviewed the lovely Stacy Reardon Hall, standardized patient program at VCU Medical Center. So, Nate, what do you think about this?
I think it's something that I've never really encountered before. Like doctors with good bedside manners. I always thought it was something that like it's just so cool to see what VCU is doing with this sort of like hiring actors to play patients, I think it gives doctors a chance to, I guess, to interact with scenarios that you wouldn't see on a normal, like unexpected stuff. Like
Yeah, and
that's
even the expected, like it's hard to really, like, you can have a plan, right? But until you're there implementing it, you don't know how you as a person is, or you don't know how you're actually going to react. So I think it's great to give doctors that one-on-one practice with somebody else before it's like their actual patient, not just learning how to diagnose and stuff, but like you said, the bedside manner, which is so important. um yeah, I wish, I I think what's so interesting about their program is because I know you mentioned to me, because you have family in the medical field, that other programs do have standardized patient programs, and they do. It is a newer to be done in this particular way where it is live people, and I think that's what was unique to VCU's program, where the theater department actually teamed up with the medical department, like two professors there, Dr. Anderson and David Leong, in the theater department, and looked into how can we use, because there's such a rich arts community in Richmond, and they were looking at, and their theater programs, like how can we integrate this, and I think there was even an MFA student that they brought in, from the article that I read, to and part of his thesis was about the program. I just think that's, like you, it's been rare to have really good bedside manner. And I know when I have, I don't know how you feel about this, but when I have doctors that have really good bedside manner, and I feel like are really listening and not judging me, I'm more apt to open up myself. And then maybe, I don't know, sometimes we as patients, we don't realize what our symptoms are because that's just our normal, right? So it's good for doctors to be able to get us talking and ask questions, because like the sweating thing that we've talked about, like I didn't realize that you're supposed to like sweat, because people say girls don't sweat, right? So I
right.
didn't realize it was abnormal for me to not sweat. I mean, I do sweat, but I should be sweating way more, way more, and that affects me a lot. So it's great to have doctors that kind of open up. And I think it's, I don't know, what are your thoughts?
Well, I mean, it's hard to be taught every scenario that could possibly occur. And I think
Yeah,
doctors, like all people, are not like question whether they should, say something or not say something. It's just,
right.
it's not, I think, what's cool about what VCU is doing in creating these like actual, and I think it's a great application of actors. Like you don't,
Mm,
when you go into the field of acting, you don't think, oh, I'm going to get a job as a medical practitioner, like do
right.
like I think that's such a unique sort of application of
Yeah,
being an actor. Like you wouldn't think like there'd be it's such a amazing tool as an actor. Like you think actors like Hollywood celebrity, like, but this is actually like actors doing good for
yeah,
humanity.
actors for community. Yeah, and I think there's so many applications of the arts that are for the community, and this is a wonderful example. And I love, it'd be really cool if like a program like this were in every single medical school, and maybe that's the lofty goal. And I messaged Stacy after the interview with some follow-up questions, and she said that the programs are very supportive of each other and communicate a lot. So when VCU was first creating their program, they reached out to other programs. to learn about how they started theirs. And now that they've started theirs, other programs reach out. Like they all share ideas, which is also very, I mean, that's wonderful because then, you're learning what works, what doesn't work. Hey, try this. I think that's great. And maybe this is a great use of theater programs in schools as well.
Yeah.
Because
I
there
mean, you
is
could,
only like, I mean, there is only there are only so many shows a year to get you by, having been in the arts and stuff. So this is a wonderful, like she said, job that helps do the paycheck, and I'm sure also supports their souls as well. And what's so unique to their program, I was reading in the article, is the actors involvement, like how the actors, and she spoke to this too, give feedback to the patients, objective feedback, not so, like, this is something I noticed. Here's some tips on how to work that interaction in the future. And they can actually be a part of grading too, which is unheard of. But I think that's so important because I don't, and I, and this is a lofty goal, but like, I really would love like doctors, like not just residents and fellowships, but like the people that are teaching the classes to go through things like this and get feedback, because it's, as part of continuing education. Because some of my worst experiences haven't been the young doctors, it's been the people that have been in there for years at places that, think they know everything. And
mm,
medicine, science, everything's always changing. Um, yeah, I don't know.
well, I mean, some of that can be generational, but at the same time, I think it serves a purpose. And I would love to see this sort of stuff. Like, I love this idea of creating scenarios around these professional situations. You just wouldn't think, like, I would love to see this kind of stuff done for lawyers or for teachers or for just like all sorts of scenarios where you'd have these people pretending to be people so that you could kind of work through that situation so that you could be ready. I mean, I'm sure the military does, like, I'm sure the military's been doing this for a long time, like working on insurgencies and stuff like, and it's this sort of like play that I think is, like the world is a stage, and just like, why can't, like, I love this concept of just playing out things like like Star Trek, like a holodeck. Like that's
Yeah,
essentially what we're doing, just like reality holodeck, like with real
right.
people.
Well, it's improv, and it's, yeah, it's giving that lived experience before it's fully lit. Like it's practice, and practice makes perfect, right?
And
It would be so cool. I think, and my ex was really working in the theater world of training actors under stress. I think it would be really cool to look into using an implementation of this type of standardized patient program for training doctors under stress, like, or doctors diagnosing under stress and duress, because um, the ER is a very stressful place, and it's a lot of chaos. There's a lot going on, and they have to triage very quickly. Not just the triage nurse, but also the doctors have to kind of figure out and assess what's going on. And a lot of spoonies and people with chronic conditions end up in the ER. And I think that also goes maybe to a misunderstanding of the best place to go when things are happening, because the ER is not for diagnosis, right? And now we have I see your face. Now we have like we have you have PCP, like your regular doctor, but it's so hard to get into these days. So then a lot of times if something's going on, you call your doctor, you can't get in, right? So then you try urgent care, and sometimes they can't handle what's going on with you, especially if it has to do with pain. And you may even have a pain doctor, but they can't see you that day. So everybody sends you to the ER. But the ER doesn't want to deal with pain patients, particularly because of the opioid crisis and a lot of the laws that are going on. But for years, that's where chronic pain patients and a lot of spoonies went when weird stuff is happening with you, because you don't know what. I mean, when I first had paralytic attacks, that's where I went, and people just were like, you know, they don't know what it is, and they're like, not every hospital has neurology on call. So that's why I was diagnosed with like a million different things, including, well, that's psychological. And so many women and chronic patients are told it's in your head, it's conversion disorder, it's pseudo seizures, and then only later to find out, much later or never to find out, there is a physical manifestation, like there's something physiological causing it. And but that's, I think, twofold. It's one, the ER really isn't a good place for diagnosis, but unfortunately sometimes they have to do a little bit of diagnosing, as part of their triage to figure out what the hell is going on, right? So maybe giving them better scenarios of these circumstances. How do you get doctors to practice under stress? Because just because they learn in the medical field, they're not really practicing under stress until they're thrown into the ER, right? So maybe finding some way to amp up the standardized patient program. I have no idea, but that's just where my brain went on a total tangent and
Clearly,
dream
clearly,
fantasy.
clearly, doctors need to be given a Kobayashi Maru of a test, so that they have to deal with an unsolvable situation
Yes.
and how to deal with that.
Yeah. No, I think that's, and she alluded to that too. Well, not alluded, but where they're given, they kind of get that, where they're given something they couldn't possibly know yet because they haven't,
Right. So they have to,
learned it yet. But I think it would also be good to know something they have learned, but something that's complex. Like, even like good doctors look at my my thing and they're like, well, you're complex, and they get intimidated by it. But it's easy when you break it down, and it's particularly easy, well, not easy, but listening to your patient will get you everywhere because they hold the answers and they know their body. They're with their body 24/7. So this
right.
is the standardized patient. And I know some of the actors that do it, and I know they love it. It's very fulfilling to
Right.
them
It's
to
gotta
feel
I
like they're
think it'd be a
helping.
very, very fun job. I feel like
Yeah.
this job would be like a fun job, like something you'd be excited about going to. Like you're going to work and your work is to just pretend. Like
Yeah.
I think that's a fun, like I would take this job if I could get it. Like it just seems like a fun job to have. Like you go to work and like, oh, today you have tuberculosis and you have to pretend like you have,
Yes,
it's
that
just,
sounds, that's a fun day when you find out you have tuberculosis.
yeah, and you have to pretend to be a person with tuberculosis. And it's just like that's your day, is this whole like imagining,
But
like
your years of experience having been a patient, I think could be a beneficial thing as a standardized patient.
oh, like if I was to do it, like I feel like I would, well, I am sick, so I can't really pretend to have another sick. So just,
Yeah.
but I feel like there's a lot you could give to that sort of um profession as a person that's actually sick, like that you could give to people who want to pretend to be
To
you.
be sick. Oh,
Yeah.
that would be cool if like the standardized patients got to talk to people with those actual
Well,
disorders and stuff.
isn't that what professional actors do when they have to play a role?
Research.
Yeah, research that
But
we would,
a lot of these actors don't get a lot, like Stacy was saying that too in the follow-up, that a lot of places that have standardized programs, don't, like with VCU, their actors may only get like a couple of hours. They get, bam, here's your diagnosis, here's what the symptoms are, your symptomology, and they have to memorize it very quick. And that's the benefit of using professional actors or people that can memorize very, very quickly, is because they're used to being able to go, bam, memorize this.
Yeah.
And
Yeah.
go. But
Yeah.
yeah, it would be, that would be, if you, okay, so if you were to be like an advice, like if in your dream scenario, what would something you'd like to see it as with a standardized patient program?
What I would like, well, I mean, I think researching a role would be a good idea. I think that it holds a lot of potential to really kind of being like you have an idea of what that type of illness is, but until you actually see it, it's just different, you know?
Yeah.
Like I
Well, and
think
like we've
people,
learned with people, like people that have the same stuff often have different experiences of it too.
well, I mean, you hear it all the time that everybody's a snowflake in the sense like with your illness, it presents as a specific way, but the individual differences are very like obvious. Like not everybody's autism's the same, not everybody's multiple sclerosis is the same, not everybody's fibromyalgia. Like it's just all these
Yeah.
things. Like, you get a label, but you're still an individual. And I think playing that role, it has that individuality to it. Like you're playing
Yeah.
a sick person is going to be very different than someone else playing that same sick person.
True. And that's probably really important to the doctor's training as well, because I can imagine, like you were kind of talking about earlier, it's really overwhelming for doctors with some of these like conditions that can manifest in so many different ways. Like you memorize the textbook, but then it's like when you're looking at a patient, if they don't have everything that's in the textbook, do they or do they not have it? And or if they present in you know, that could be overwhelming in the diagnosis process.
I mean, that gets into the individuality of people, and illnesses is a broad term.
Yeah.
When you break it down, like your illness is not the same as like another person's illness, even though you have the
Yeah.
same label. It's not the same disease for you, and it can be. And people's illnesses, they change over time, especially
Yeah.
mine. Like I'm not the same MS patient I was a decade ago, and
Same.
I
Yeah.
don't think it will be a decade in the future. It's just I still have the same label, but it's just, I mean, and that's why a lot of these diseases have sort of a breakdown of, you know, with mine's relapsing, remitting, but there's also primary progressive, but still that only instills like this very gross, broad idea of what I'm dealing with.
Right. And like with the Ehlers-Danlos community, there are multiple variants of Ehlers-Danlos, but like each individual variant, like I have hypermobile, like which is not rare, and there's a large populace of that, and so many people, like I'll talk to people online, and we have things that we can connect to, but then there's other things where it's like, oh, I've never had that, or I have things that they've never had, and because everything's different. And I think we put, because we are scared ourselves, and kind of like some days, you know, we're desperate to feel better, desperate to, we can get in a rut of being desperate to fix this, desperate to find a cure. There's a lot of pressure that is put on doctors to be that answer and have that answer, but there is no way, and I think Stacy said this, there's no way that they can know everything. They are not God. They're not, they're human. They're fallible, and that is okay. And I think at least with a program like this, you're giving them opportunities to
Practice.
to fix that, to practice and work on that communication with their patient, because I can't tell you how many times I've looked back at the notes and my history is so incomplete, you know, and I realize years later doctors don't realize these things about me. And I know that with other patients as well, and like history really, really helps with a diagnosis. Not just family history and your history, but like history of symptomology and when things started and how things started and all of your symptoms. And that can help from better communication with your patients and stuff. So
Yeah.
yeah, I'm excited to see, and I think it's really cool that she's already like she's having doctors treating her children that started in like that first generation of that program. How cool is that? Like to be
Yeah.
part of a change at an institution and you're seeing the change and you're seeing it um work. I think that's really, really amazing.
Yeah, I agree. It's,
Yeah,
things need to change.
yeah,
They are not the greatest, and I feel like this is a positive change that I'd like to
very
see
positive.
across the board.
Yeah, it's like there's a book that we read in when I my social work school um where we were told that a lot of med schools also have students read the book and now I can't think of it, but it talks about a family with a daughter with epilepsy and they're they can't they're non-English speaking. And at that time, the hospitals and doctors' offices really didn't have translators for their language. Um, and I mean, this child essentially, she had lost huge deficits because she went into coma-like episodes of epilepsy, and it was just devastating to read through the whole and the hospital's yelling at the parents for not giving her the medicine as prescribed, and the parents are kind of upset with the hospital because they've been trying to communicate the reason they don't give it to her is because of the symptoms the child is having about the medicine, and how much could have been fixed, including this child's life, if they had been able to communicate to each other. And that makes me sad. So I wonder, and now I'm thinking of this question. I wonder if they practice situations where you're dealing with a non-English speaking patient.
We'll have to
But
ask on the follow-up.
on the
I don't
follow-up, yeah.
I don't know if that's a scenario that they can, like, I know there are some
But we do
languages.
have more translators now. Like, yeah,
Yeah, and I think it's more commonplace for doctors to know Spanish and stuff like that.
yeah,
Like, I think it's just there's a growing need for bilingual or multilingual
yeah,
people in the medical profession.
yeah. Interesting. Yeah, and I think this is like reading that book kind of gives you an understanding, but then going through a program like this with standardized patients and working one-on-one, I think would give you a whole other level of understanding of
Yeah.
how your communication and how your bedside manner affects your ability to diagnose, but and also your relationship with your parent patient. Yeah. And do you like, I think it's important to have a good relationship with your patient. How do you like, do you think that that is necessary or important to being able to have to diagnose or being a doctor?
I don't think it's important to being able to diagnose, but working with a patient, like I know in my profession, it's heavily emphasized that your patient is not your patient is your partner in a sense. Like you're not telling your patient what to do, you're working together with your patient. I think that's important to
Uh,
realize that it's not just one, it's not like a authority talking down to you, it's more of a collaboration between the
right.
two. That patients, I think that also breeds better compliance. Like patients
Mhm.
aren't going to take your advice if they don't like you.
Yeah,
At the end of the day, you're the one that has to take the medicine. You're the one that has to get the surgery. You're the one that has to do the work.
Right.
Like doctors can tell you what to do, but they can't do it for you. So that requires a relationship, the positive one.
Yeah. Very true. Very, very true. Cool.
Right.
Well, I really loved having Stacy on and learning more about the program. I think it would be great to have some of the actors from the program, or maybe even some students who have been through it, other people involved in the future, just to keep learning about this program and other programs out there. So thank you, Stacy, and thank you, VCU School of Medicine and VCU School of Theater. We appreciate what you're doing and for coming on here to our podcast. And for those of out there listening and following, stay tuned, because at the end of the month, Nate and I will be interviewing each other for our personal story of disability. And then we will also be announcing February's upcoming episodes. We've got some great stuff in store for you. And we will be celebrating the month of love with Dateability, the online dating app for those with disabilities, chronic illnesses, and supporters. And then also we have a personal story of disability from a gentleman with cerebral palsy. Thank you, and save your spoons.
If you want to contact us, please send a DM or email to speakinginspoons@gmail.com with any stories you have or would like to interview with us on any of our upcoming topics. And check out our website for all of our upcoming episodes and what's happening in the Speaking in Spoons community at www.speakinginspoons.com. Thank you for listening to Speaking in Spoons, and have a great day.